Did you know that 1 in 10 women worldwide live with endometriosis? Yet, it takes an average of 7 to 10 years to get proper diagnosis. That's over a decade of pain, uncertainty, and often being dismissed by healthcare providers. Endometriosis isn't just a bad period, it's a chronic condition that affects millions of women. Yet, it's widely misunderstood. Hello, and welcome back to the Gayu podcast, where we explore conversations that inspire, inform, and empower. I am Gayu, your host and advocate for holistic wellness. Today, we're diving deep into this critical issue with a true expert in the field. Joining us today is Dr. Marlain Mubarak, authority in endometriosis care and minimally invasive gynecological surgeries. With advanced training from the Oxford Deanery and years of experience at the Oxford Radcliffe Hospital Endometriosis Center, Dr. Mubarak has dedicated her career to improving the lives of women with endometriosis. Now, she leads the Endometriosis Center at the King's College Hospital, where she combines cutting-edge technologies with a compassionate, patient-led approach that helps her deal with her patients with endometriosis and treat them with the best holistic care. I am super thrilled to have her here, share her expertise with us. Let's get started. Dr. Mubarak, again, I'm super thrilled to have you here with me today.
Thank you very much. I'm so happy to be here. And this is a topic very close to my heart. As you said, it affects 1 out of 10 women. However, there is something called as well adenomyosis, which is endometriosis of the muscle of the uterus, and it affects 25% of the women.
Wow.
So it's a huge problem, having a significant impact on women. The delay in the diagnosis is frightening. Women being told it's in your head, it doesn't exist, everybody have period pain, get on with it, you need antidepressant, and it have not just the pain, it's the impact on work, studies, the rest of the family. It's not fun to see your loved one in pain, affects fertility, premature ovarian failure, premature menopause. It's an inflammatory disease, joint pain, migraine, chronic fatigue syndrome. It's all associated with endometriosis, but it's the beast that nobody wants to talk about or do anything about it.
Okay. Wow. You mentioned a lot of things in the list. But for listeners maybe who don't know what endometriosis, what is actually endometriosis?
The studies in Oxford showed it's a genetic disease. There is familiar tendency. However, my ladies will say to me, I have nobody in my family who have endometriosis. When you start digging in, you will find aunties couldn't get pregnant, mom had hysterectomy because of heavy period or fibroids. The difficulty in the diagnosis, because we traditionally used to say laparoscopy is the gold standard. Laparoscopy is surgery, it's invasive. It's no more the gold standard. Ultrasound and MRI, but it's in the expert hand. Unfortunately, there is a handful of us in Dubai who can do ultrasound for endometriosis. MRI to be reported properly for endometriosis with the minute detail, there is barely 5 radiologists. And I have 3 of them in King's because I can't do complex surgery without knowing what is what. And I always tell my ladies, would you sign a blank check and give it to somebody? No. How would you allow a surgeon to go inside your tummy without knowing what they are doing, the impact on you, the outcome of the surgery? The devil is in the details with this disease. So ultrasound can show it. The criteria of diagnosing on ultrasound have changed so many times in the last 5 years. What is in the textbook is absolute, is out. We need to be up to date. Hence, I do a lot of lectures for doctors in conferences and on Zoom, various forums to train and teach doctors how to diagnose it. The trick is in the diagnosis. Pain is not in your head. Pain is real.
So you said it is genetic. And you said it's mainly caused, again, due to inflammation. And, we just spoke about inflammation just before we started, that the foods you eat or the way you live causes inflammation in your body, which can it cause endometriosis, or can it trigger in alleviating the symptoms?
There is so many theories about the origin of endometriosis. So we believe now most probably it's interaction between genetic, environmental, and immunological factors. And that's why you tend to see women who have endometriosis tends to have repeated pregnancy loss, repeated failure of IVF pregnancy, implantation failure, biochemical pregnancies. And when we start looking into it properly, I work with a team. You know, my end result is not just credit to me, it's to the whole team I work with. And when we start looking into the immunological disorders, we tend to have a lot of these women having immunological problems, which, if managed properly, then we get pregnancies and we get a fantastic outcome. We need to think outside the box. We need to think to be up to date on the latest research. And this is how we can really change the quality of life of these women and the outcome.
So, doctor, when you say endometriosis is genetic, at what age does this condition start developing, or is it right from the birth?
Very good question. So studies on babies that been miscarried at 20-25 weeks, we found endometriosis cells in their organs. However, it kicks in the moment the period starts, the menarche. And that's why young girls who have severe period pain from the time the period starts, that's endometriosis waiting to be discovered. It's a rule. Period pain score 3, 4, 5 out of 10, most probably it's not endometriosis. However, when the period pain 7, 8, 9, 10 out of 10, can't go to school, have to go to the emergency to take painkillers, that's 100% endometriosis, just waiting to be discovered. The problem is when you do ultrasound for these young girls, 12, 13, 15, 17, you won't find anything on ultrasound because it's just non-clinical, it's very tiny disease, you don't see it. On ultrasound and MRI, it's only later on, after the age of 20, you start seeing it. So it's a progressive disease. What I try to do is, I go to schools as well, is to make young girls aware that period pain is not normal. There is interventions that we can do to prevent it from progressing. Okay. And this is where it's important. The earlier we start, the better.
So you just spoke about that you can do to prevent it from exacerbating. What can we do?
So there is one study that was done many years ago in the UK, and that study basically they did laparoscopy on young girls between the age of 12 to 24. And they found they have endometriosis. They put them on the oral contraceptive pill. And a year later, they repeated it. Interesting, only 10% of these young girls, their endometriosis got worse. The rest, 90%, either completely disappeared or stayed the same. So for me, 90% are better. How the medical treatment works? So if you have a plant, stop watering it. Basically, it will stop growing. It might not die, but it will stop growing. Endometriosis is the same. Endometriosis itself releases estrogen. Estrogen is the hormone that makes it grow. It feeds itself by itself. Unfortunately, all the medication we use are hormonal, which have side effects. However, the good news is, I am more and more using a natural progesterone that comes from yam, sweet potatoes. And it's giving me fantastic results. There is nothing called zero pain with endometriosis. If we reduce the pain score down to 4, 5 out of 10, that is success. But medication is not the only thing. The lifestyle changes is so essential. So as I said, endometriosis is an inflammatory disease. Certain type of foods are inflammatory foods, such as gluten. For some women, it's lactose. All these E numbers in the food, the processed food, it's all inflammatory food. So this is where the change in the diet improves the symptoms, especially what we call the endometriosis belly. I have a young lady on Saturday saying to me, can you see, my tummy is so swollen. I am so skinny. And I said to her, this is the endometriosis belly because it causes irritation of the intestine. The bowels becomes full of gases. That makes the endometriosis pain even worse. So the changes in the lifestyle really, really helps.
Are there any specific lifestyle changes that you would say? You spoke about, of course, taking any inflammatory foods. Anything else that can complement?
There is a lot of work that had come out in the last 12 months, which using anti-inflammatory as antioxidants, natural food supplements, such as omega-3, selenium, CQ10, vitamin D, B12, vitamin C, vitamin E. All of these are actually anti-cancer. They reduce the inflammation. They are available in our natural food, such as, sweet potatoes, in nuts, in walnuts, and in eggs, salmon. But unfortunately, our current lifestyle, we are more into junk food, burgers, bread. We need to go back to eat the same way as our ancestors were eating, back to basic, all the colors of the food in your plates, eating small amounts, portion size. Try to avoid the processed food and the E numbers. We know processed food is associated with increased risk of cancer. So this is where the diet, adding the antioxidant, which actually improve the functions of the ovaries. So every little bit helps. There is not one magic answer. Medication on its own is not enough. Diet on itself is not enough. So it's the holistic approach and exercising. Exercising make us release the happy hormones plus the natural painkillers, the natural morphines. And that's why women improve. However, they come to me and say, I am in so much pain, I can't even go to the gym. So we have to individualize the approach. We don't look the same. The approach to each woman is completely not the same. So we really, really have to look into details. And that's why my consultation ends being 45 minutes. And I'm always constantly apologizing to my patients for waiting outside. And I'm surprised that they keep coming back. I guess they are better. That's why they keep coming back.
So, doctor, you spoke about medication at one point, and you said generally oral contraceptive pills are given. Is this something that somebody who's diagnosed with endometriosis has to take for the rest of their life, or is that something that they can take for a certain period and stop?
To be honest, this is a good question. So far, we know it's a chronic progressive disease. My first training in endometriosis was back in Oxford in 2004, 2005. And then from there, I've gone all around Europe to Endometriosis Center to do advanced training. And I set up an Endometriosis Center in the UK in 2014 until I came to Dubai in 2018. And I brought the center with me here and I set it up in Dubai. And so I see a huge number of women. Unfortunately, 70% of my patients are endometriosis patients. It's a debilitating disease. Interesting what I see in the UK. If you go to your GP and say, I have period pain, they will stick you on the oral contraceptive pill. And most of the women are okay on it. A very small number of women have side effects. And when I see these women, their endometriosis is not as bad as the other young ladies who've never used anything. Contraceptive pill is safe, but we need to do a risk assessment before we prescribe it. It's not for everybody. There is a lot of options. So we need to work with an individual woman and find the thing that is going to work for her. If she's trying for a baby, we need to use the type of progesterone that is not going to stop her to get pregnant. If she is, have migraine, she can't use the combined contraceptive pill. We can use the progesterone-only pill. Everything has side effects. And I always say to my ladies, it's like shopping for a dress. You see it, you think, oh, I love it. You put it on, it doesn't suit you. The same thing with all these hormonal medications. I pick up something, depends on the history and the pain and what I find on the ultrasound, and a lot of the time I have to change it. The one side effect that is horrible is depression. Women who have endometriosis associated with higher incidence of depression. I guess it's not easy to be in pain all the time. And all hormonal treatment have this side effect. It's a small percentage, but I always warn my ladies, if you're feeling low in yourself, not yourself, we need to stop it. It means it's not the right one for you. I need to find something else. This is where, my natural, the natural progesterone, it's called uterine, which we use it for hormone replacement, is actually giving me really good result. It's not magic, it's not zero, but it improves the pain without any side effects, except it makes you sleepy, so you take it at bedtime. So it's fantastic.
Okay. Very interesting. When you start talking about it, it's like so many things that come to my head. So you said, so painful period is one aspect of it, or is it the only aspect?
No. So 75% of the women who have endometriosis, adenomyosis have symptoms. 25% it is silent. The silent are the worst one. So endometriosis can be in the muscle of the uterus. We call it adenomyosis. If it's just in the muscle of the uterus with nowhere else, it can, they tend to present with just period pain at the time of the period, heavy periods, low back pain, painful relationship. Other symptoms is that nobody tells you about is the typical irritable bowel syndrome, the bloatedness, diarrhea, alternating with constipation. It's usually due to the irritation of the endometriosis to our intestine. Bladder symptoms. It irritates the bladder, going frequently to pass urine every 5 minutes. You pass small amount. I have some women who actually stop drinking because every time they go to pass urine, it's really painful. Women come to me with just repeated urine infection, and they just come for a quick urine analysis, quick, antibiotics. When I start grilling them, taking a full history, I discover they have endometriosis. It's important to address every aspect of these symptoms and look at the fertility aspect. As I said, endometriosis is an inflammatory disease. So one of the things endometriosis, the endometriotic tissue itself releases cytokines and killer cells, which are the mediator of inflammation. However, they affect our eggs. We are born with a pool of eggs that we use through our life. They destroy them. They affect the quality of the embryo if a woman gets pregnant, the transport through the tube, and the implantation.
Okay.
So this is how it affects their fertility. But the impact on the ovarian reserve is frightening. I see women in their, early 30s, and usually ovarian reserve is completely fine until the age of 38, and their ovarian reserve is really poor. I check every woman who comes with period pain and assess her ovarian reserve by doing just a simple blood test called AMH, anti-Mullerian hormone, day 2, day 3, or day 4 of the period. Plus, I do an ultrasound, day 5, day 6 of the period, day 4, to count the number of the follicles on the ovaries. And it gives us a really good idea. It's a good wake-up call. We might need to think about, don't delay getting pregnant. Let's take the antioxidant. However, I give it to all my patients. Let's think about egg freezing or embryos freezing. It's your money in the bank for the future, because women are following their career, and you are not obliged to just find any man.
Yeah.
Because you really want to have a baby in your life and you don't want to miss that chance. So there is a lot of things that we can do.
Just spoke about, women having babies later. I know maybe completely off topic, but the whole geriatric pregnancy, is that stress on the women, or, that's the latest studies that are saying that the men live longer when they have babies after 40 and stuff like that. I don't know whether it's true. Just wanted to get your opinion.
So the thing is, our life have changed. Women and men are equal. We all have to provide. A family can't rely on one person's salary. The couples will have to pursue the career, whether it's a man or a woman, both. So we delay the pregnancy because this is the environment we are in, because we can't be able to bring children to life and look after them, educate them, unless we have a good job. So this is the nature. And also we are only having 1 or 2 kids. We don't want to have more. We are unable to afford having too many kids to bring them through life. So up to the age of 38, if there's no endometriosis, there's no problem. then we don't need to worry. However, one of the things I've done in King's is I set up a fertility checkup package, because it's really good to know where you stand and then think, okay, I'm fine, I will do that checkup on a yearly basis, because things change. Women are not obliged just because they want to have a child to have it now and affect their life. One thing you said, we are living longer, we are healthier. We are so focused now on exercising, eating healthy. Our lifestyle is changing into a better lifestyle. And actually, my youngest lady at the moment, she's 47. This poor lady with adenomyosis had so many IVF cycles failed, so many embryo transfers with the donor egg. She's just really wants to have a baby. That failed until we discovered what's actually, it's a simple problem, and we're managing her, autoimmune problem. And she is now 27 weeks pregnant. I'm so
Wow.
she's fit, healthy. She will have a lovely baby. So, yes, we can have a baby as long as we are fit, healthy at any age. But our eggs, that is something we need to be aware of. That's why egg freezing is becoming very, very popular.
Yeah, I've heard about that. Didn't have to go through it personally. Talking about, when you spoke about period pains and irregular periods or whatever that happens, people generally associate that with PCOS or PCOD. They never think that it could be endometriosis. Have you had, patients talking about it?
Good question. I have a lot of women plastered with severe endometriosis and been labeled as PCOS, and they have no PCOS whatsoever. The percentage of women who have polycystic ovarian syndrome is 10%. The diagnosis, we have to fulfill 3 criteria. Criteria number 1 is irregular period coming every 2 months, 6 months. That doesn't exist. It means it's not PCOS. The other criteria is multifollicular, as seeing on the ovary a lot of follicles, more than 12 on each ovary, which we call them cysts, but they are not cysts, they are our follicles. However, we can have multifollicular ovaries, and I think because of our lifestyle, we are eating a lot of meat, there is a lot of hormones pumped into it, we tend to see more multifollicular ovaries. And the third one, from the blood tests, the excess weight, but you need to have the 3 criteria. If you don't have these 3 criteria, you don't have polycystic ovarian syndrome. And, unfortunately, women are labeled with things which are not true.
That's why I said I had to ask this question, because that's like, I've been labeled that I've got PCOS myself, but I have had no issues with anything. But luckily my doctor never put me on any medication or any pill. But I'm just saying that I had to ask this question because I think it was just personal.
It's a big misdiagnosis. So you need to fulfill the 3 criteria. You don't fulfill them, then sometimes I think we gynecologists haven't learned anything from the medical books except PCOS.
Say, oh, that's the chapter I'm going to focus on. Doctor, talking about menopause, I'm a menopause coach. So you said that women with endometriosis end up having a premature and early menopause. Can you talk us a little bit about that?
So as I said, endometriosis can affect our follicular count. And there is a lot of studies which showed women who have low AMH, the very low AMH is predictive of menopause, when it will happen. Before the menopause hits, which is no period for 12 months, that's the definition of menopause. In the last 2 to 10 years, until the menopause hits, women tend to have symptoms. The hot flushes, night sweats, irritability, poor sleep, vaginal dryness, repeated urine infection, itchy ears. Nobody tells you itchy ears is the drop of the estrogen, is the perimenopause. Dry eyes, skin very itchy. There's 43 different symptoms. For me, the most important is the brain fog, poor concentration, poor focus, inability, the processing becomes slower. And that's why you see women, they are at the top of their career in their 40s, 45. Then these symptoms hit. They start thinking, am I having, early dementia? And they stop, going forward in their careers and progressing. I had one lady who is a lawyer, and she said to me, I want hormone replacement. No matter what, it's the risk. I can't function. I'm ready to have, to die because she had a blood clot in her life in the past, and that's a contraindication for a hormone replacement. But I can't function, and fair enough. And these are the things that nobody talks about. So hormone replacement. So a lot of women with endometriosis had a hysterectomy. Even if you leave the ovaries behind, we know that in a year or 2 years, the ovaries pack up and stop functioning. So it is important to use, if the patient have no contraindication as no personal or very strong family history of breast cancer. So we have to do a risk assessment. Then they need to have some hormone replacement. Do you know that 7 out of 10 of people with Alzheimer are women, not men? Because the estrogen level drops, and we start putting amyloids layers in our brain, which is the one that predisposes to Alzheimer, dementia, Parkinsonism. And hormone replacement, there is 2 different type of hormone replacement. There is the old-fashioned one, and there is the bioidentical. However, we have even now a tablet form, which the progesterone inside it as well come from yam, which have no impact on the breast, and there is no risk of breast cancer. So even in women who had surgery, hysterectomy for endometriosis, we still need to think about using both estrogen and progesterone. The thing is, we had always been saying estrogen is the most important hormones for our body, and the progesterone have no value except if I give estrogen HRT only for women who have a uterus, they can end with cancer of the uterus. But actually, we are now discovering that even the progesterone have an important role in our sleeping, relaxation, in our, concentration. There is more benefits to it. And of course, using testosterone because it have a big role in our muscle mass, metabolism. Medication is not the only thing. The lifestyle is so essential. Medication is only a small part of our healthy life, in our longevity, and our brain ticking and being healthy even late in life. And now we know that 1 out of 3 women will reach the age of 100. So it's not about how many years we live, it's being healthy.
Yeah, it's the quality of life.
It's the quality of life.
You spoke about hysterectomy. Just for the listeners who don't know what that is, could you enlighten them?
What we are talking is about removing the uterus with or without removing the cervix, which is an option when we exhausted all the other conservative options. For women with heavy periods, large fibroids, uterine adenomyosis, endometriosis, medicine have actually moved so fast. There is non-surgical options like uterine artery embolization. It's basically like stopping the plant from growing by stopping it from getting the water. The same thing as done by the radiologist. I have an amazing radiologist in Kings who does it for me. And basically it involves an overnight stay. You go into the main blood vessels that feeds the uterus, done under CT scan. You put some tiny particles. It reduces the blood going to the uterus. It shrinks the fibroid by 70-80% over 6 months period. It can be suitable for women with adenomyosis. It's another alternative. We all have to have options, and I don't let anybody tell me what to do. I need to understand what are my options, what is the benefit and the risk of each options. Then I will make my decision. And this is how, I approach all my ladies.
Women who've gone through hysterectomy, can they still start HRT after the surgery?
The British Menopause Society and the American Menopause Society, we start HRT within 10 years of the menopause. whether it's surgical menopause or it's a natural menopause. Why is that? Because the longer you leave it, we already by then have developed cardiovascular problems. The HRT is not going to give us the benefit. On the contrary, there is more risks. So one of the advantage of HRT is protective for our heart.
Yeah.
For our mind, it reduces estrogen, reduces the insulin resistance, and the estrogen as well reduces the cholesterol level. So that's why the earlier you start it, the better you get the benefit from it, with no risk if you started after 10 years. And this is where the American Million study that was reported in 2003 stopped women from taking HRT because it freaked them about the risk of breast cancer. The problem with that study, which already have done a lot of damage, but when the data was reanalyzed, they had started HRT in women who are in their 60s and 70s. Hence, you have significant risk of breast cancer. But we need to remember, we need to do the screening. So if a woman come to me, I will make sure she have her mammogram, breast ultrasound, pap smear, the full checkup. We really need to have a yearly checkup, whether we are on HRT, without HRT, we are young, old, we need to have a yearly gynecological checkup.
Doctor, just one question which one of our listener wanted me to ask, and I think you've addressed this already, where the question is like she's got fibroids and has had painful periods throughout her life, and right now the doctors only suggest hysterectomy as the only solution. And you mentioned that there are other options and that you should reconsider before approaching hysterectomy. Just wanted to get your feedback on that.
I always say 3/4 of the treatment is accurate diagnosis. Once you establish accurate diagnosis, then you can treat properly. Period pain might not be the fibroid. There might be endometriosis undiagnosed. Hence, I do always an MRI for all my women who come, whether I'm going to do hysterectomy for them, myomectomy, or whatever. It's really a key in establishing accurate diagnosis, and I have an amazing team who gives me results accurately. So endometriosis, adenomyosis, fibroids are all hyperestrogenic states. And you see them together in 50% of the women. Depends on the size of the fibroid and the location. We sometimes can do a myomectomy, as just remove the fibroid. If it is inside the uterus, we can do a simple procedure from inside the cervix and shave it. As I said, uterine embolization is a fantastic option for women who don't want to have a hysterectomy, and definitely it is suitable for most women. So yes, there is options.
Thank you. It helps people understand when, if the medical provider is just giving you one option, I think it's always get to from an expert opinion. Doctor, are there any organizations or resources that you recommend for women who are seeking more information or support? Are there any support groups in UAE?
So I started the first endometriosis support group in the UAE back in 2018. I think things have changed. The women have, Instagram, the bloggers, it's the support group doesn't work. And there is a lot, I'm so well aware that there is a lot of women support groups that we doctors are not aware of it. We don't know, we don't access it even. And I find a lot of women come to me because they said to me, I've asked the questions on the support group and everybody said I should come to you. Endometriosis UK is a good one. Endometriosis Australia is a good one because now a lot of the celebrities and the big A-lister actresses had come out and said, I have endometriosis, I've been fogged off and been told for years and years there is nothing wrong with you, you are completely fine, until 20 years down the line I discovered that I have really bad endometriosis. So as I said, period pain, anything more than 5 or 6 out of 10, you need really to find somebody who gives you an answer. Don't be fogged off, and don't take anything face value. Ask questions.
I know the doctor that our listeners can come to see you at the King's or a college hospital. But is there any other place that they can follow you? Are there any places that you share more of your information?
King's, we are doing a lot of things for endometriosis. I only work at King's, and it's one of the top hospitals in the UAE. And I have an endometriosis team. So we are an endometriosis center. We are expanding now because I want to get more, surgeons to come and be able to do the complex surgery. I have the top, the backup from a top urologist, top radiologist, and that really makes a difference. Hopefully, there would be more and more of us who can do the complex surgery. The easy surgery is easy surgery. However, one thing I really want to say, I only operate on 7% of my women. You have really to be careful before you jump into surgery. You never dive into a pool without assessing the depth of it. If you have a cyst, don't rush into getting it removed, because that can be a negative to you. Ask questions. Being British trained, British women always ask their doctors, what's your result? How many have you done? What's your outcome? What's your complication rate? If a doctor fogs you, run away, find somebody else. This is the rule.
Amazing. Any final words of encouragement for the women with endometriosis?
Pain is not in your head. Pain is real. The earlier you address it, the better. But it doesn't have to be only taking hormonal treatment. Lifestyle changes makes a huge, huge difference. I know it's not easy to be gluten-free. All my ladies who go gluten-free, they never go back to gluten. They might occasionally eat it on holidays or the weekend, but they notice the complete difference to the lifestyle changes.
Amazing. Doctor, before we wrap up, we've come to the last segment of the podcast. I call this the 1%. Reason being, 99% of the podcast speaks about women wellness. But all said and done, men are a part of our lives too. So we've got this 1% dedicated towards them. What is your 1% advice to the men in our lives? What can they do better to support the women?
To be honest, the woman I have, the man is so supportive, because it's not fun to see your loved one in pain. It's difficult to understand it. We feel guilty because we feel helpless to help our loved one. Sometimes it helps to come with them to the consultation to understand a bit more. I had one of my ladies who is beautiful, amazingly beautiful, mom of 2 kids. And on her period, she would be sitting on the floor in pain. And her husband would say to her, "You look amazing. I don't understand this pain." Pain, the problem is not something visible. And she actually made me record on the mobile something for her to give to her husband. After the surgery, she's a completely different woman now. Her life is back to normal. And now her husband says, "I'm happy. My wife is back. The one I knew before, the smiley, happy one, is back." So, yeah, come to the consultation with your lady occasionally.
Thank you so much. I think men need to be there. I mean, I think men are there nowadays, but I think the more they get involved in our lives, I think even better.
Thank you very much. Thank you.
That's a wrap for today. I had an amazing time, and I think I know quite a bit about endometriosis, maybe 1%. But if you have any questions, feel free to reach out. We'll have the details of Dr. Marlain Mubarak anyways in our podcast. Until next time, menopause. Why pause? Let's play.